Hey, Dr. Jacobs, how are you?
Can you hear me?
I can. Are you
I'm
able?
well. Good morning.
Excellent. So I'd like to
Good
introduce
morning.
Dr. Jacobs. Dr. Jacobs is the adjunct associate professor at St. Louis University School of Medicine. And to turn it over to you, Dr. Jacobs. Take it away.
Well, good morning, everyone. And hopefully this 3-hour program will be of benefit to you in your private practices. I am, like most of you, in full-time private practice and have been for many, many years now. And I was asked to cover the subject of toe web space infections, which can range from a rather minor in presentation, as you see on the left, to secondary cellulitis and rather significant pathology. These are my potential conflicts in this. I would like to mention that this year will be the 35th year for the St. Louis Podiatry Seminar, and it will be held January 13th and 14th here at I'm speaking to you from Orlando, Florida, and the meeting will be a hybrid meeting. It will be live from the Swan Hotel. So those of you in January that have had enough would like to finally get away and interact with your colleagues, we have a wonderful meeting down here. If not, it is available virtually. And like this particular program, we concentrate on primary care podiatry. So those of you that are the super surgeons and want to hear lectures on total ankles and Charcot joint reconstructions, you're welcome to go to other meetings. If this is the type of meeting you prefer, then you may consider attending either virtually or live for this meeting. Now, the subject is that of web space infections, but I do want to concentrate a bit in the area of the diabetic patient, although the principles we're going to discuss will be applicable generally to practice. All of us know that one of the biggest advantages of being a podiatric physician in looking at the diabetic foot is the recognition of the multifactorial nature of the problems that can lead to ulceration and infection and eventual limb loss. And our job as a podiatric physician is to decrease the risks for amputation. And we certainly cannot eliminate all amputations, but every study that's been published has shown that when you add a comprehensive foot program to an endocrine clinic or a diabetic clinic, the rates of major amputations reduce. And there's no one in medicine that could bring the entire package in terms of looking at the patient and assessing potential risk factors that could lead to ulceration and infection and modifying them at an early stage. So this requires some knowledge, for example, of dermatology, such as being discussed in this meeting, vascular disease, neurology, biomechanics, perhaps some surgical procedures, gait analysis, and this type of thing. And while there are other specialists that could bring more expertise to the table in a particular area, for example, we would assume that an interventional cardiologist would know more about vascular disease than a podiatrist, or a neurologist may know more about treating neuropathy than a podiatrist. It takes a generalist viewpoint, and that is where I think we have the incidence of amputation and also improve quality of life. For example, when you treat paresthesia or dysesthesia in a diabetic patient, however you do it, whether it's supplement therapy or vitamin therapy, anti-seizure medications or tricyclic antidepressants, or however, you're also improving quality of life. And this means monitoring the patient for modifiable risks, and these are listed here for you, which you are familiar with. And again, in this particular discussion, we're going to talk about web space infections. Dr. Lehrman spoke to addressing some of the common and unchondrologic disorders that require biopsy, and the subsequent speaker will be addressing onychodystrophy and onychomycosis. So in your role as a podiatric physician, we want to identify patients who are at risk. And this takes time. There's more to treating the diabetic foot than cutting or reducing toenails and selling them diabetic shoes once a year. And so you want to identify risk factors, be they neurologic or vascular or biomechanical or deformities, whatever, at the earliest stages, and then initiate treatment for the management of these problems in order to improve quality of life and hopefully prevent amputation. And it goes back to a philosophy expressed by the greatest medical teacher of all time, Sir William Otter, over 100 years ago, who pointed out it's more important to know what sort of patient has the disease than to know what sort of disease the patient has. So it's not so much that I look at the note and says, it's like, what are the components of that diabetes affecting that lower extremity? Job at time, risk factors, and then I think dictate patients. I work with a particular pharmacy for dispensing, and the pharmacy always tells me that I have the highest fill rates of any podiatrist they work with, meaning patients who are paying out of pocket for these prescriptions. I had the highest rate of patients willing to do so, and I always tell them the key is patient education. I think if you sit down with patients and tell them you are diabetic, you know you are at risk for amputation, here are the risk factors that we can modify, that you can modify together with me to reduce the likelihood of amputation, patients are more likely to cooperate. And this is going to include the treatment of web space infections, and it's also going to include, as the next speaker is going to discuss, treatment of onychodystrophy, whether it's topical or oral medications, for example, for onychomycosis, or perhaps some urea or whatever it is you're using for non-fungal nail problems. You then implement that therapy. You then have the patient come back, of course, for their at-risk foot care, and you're going to follow up on that additional diagnosis and management that's initiated and determine, is it working? If so, we'll continue that therapy. Is it not? Do we need to modify that therapy in some manner? Has the patient had any side effects from those medications? And then continue on. So we want to take this from toenails to total care. And that means, again, evaluation of all these risk factors. And a good example of that is edema. Edema contributes to web space infections because we lose that space and aeration between the toes. Diabetics tend to get edema more than non-diabetics because of their age with venous insufficiency, cardiac disease, congestive heart failure, for example, renal disease, or other generalized fluid or electrolyte abnormalities. And if they have hammer toes and they swell, then their shoes become tight and this becomes problematic. So even simple things like initiating compression therapy for edema, or using an intermittent sequential lymphedema pump, or telling the patient, listen, you have neuropathy, your shoe may be ill-fitting, you don't appreciate that because of your neuropathy, you have this swelling, I want you to go to a pediatric facility or some other reliable facility and have your shoes properly, your feet properly measured and your shoes properly dispensed. It's a variety of little issues like that that can make all the difference in the world. So in my opinion, the majority of patients that you are seeing presently for at-risk foot care do have additional risk factors for ulceration and potential infection and amputation that need to be addressed. For that reason, I would argue that the majority of patients that you are seeing in your practice, whether it's for web space infections or onychomycosis or neuropathy or vascular disease or biomechanical abnormalities, whatever it may be, that the majority of your patients should have an additional office visit associated with that with a 25 modifier. In some instances, if you're seeing them during their global period, because once you start doing nail care, as you well know, you have a global period involved. But if we're using drugs that are short acting in onset, for example, a gabapentin for treating neuropathy, you may want to see that patient during that global period. So you're going to make increased use of those 24 and 25 modifiers. Now, the people that like to scare you and tell you, well, if you use that 25 modifier, then Medicare is going to come and put you in Medicare jail. And that's simply not true, and it's simply ridiculous. Documentation is the key. You want to remember that that 24 or 25 modifier means that there's been an evaluation and management of a problem independent of that routine foot care or at-risk foot care, or however you want to word the treatment of that onychodystrophy or onychomycosis. So make sure that your note shows that you have evaluated a problem, you have included a differential diagnosis, you have made a diagnosis, you've prescribed a particular therapy for treatment of that problem, and then on subsequent visits, you reevaluate that problem, that you make a determination as to the accuracy of your prior diagnosis, whether there's presence or absence of any side effects of that medication, whether you're going to continue that medication or not. So you want to be a doctor. If you're running into the room with a nail clipper in your hand and you just cut the nails and say, I'll see you in 10 weeks or 12 weeks or whatever your routine happens to be, and then once a year you're selling them shoes, and that's your extent of diabetic foot care, then you can't be upset when that patient disappears for a while and they come back with a cast on their leg and you say, what happened? And they said, well, I broke my fifth metatarsal, so I had to go see a doctor for this, because you've set that tone. And I think that you've got to set that tone in terms of being a complete doctor managing all these risk factors at the time of the very first visit. And the nails are the last thing that gets attended to. And when I do my notes, it's similarly the last thing that's attended to. So I would argue strenuously, having been in practice for a lot of years now, that the key to obtaining patient compliance is education of that patient. Sitting down with them, taking that time. Remember that that you can bill for time, not only complexity of the diagnoses or number of diagnoses and complexity of decision making, and educate that patient. And frequently I will include in my note how much time was spent with that patient and what percentage of that time was devoted to consultation with that patient regarding risk management and diabetic ulceration prevention and diabetic foot care. And that is included in my note back to the primary care physician, and they liked seeing that. And I tried to install this philosophy to the patients, as the great Benjamin Franklin pointed out, that many of the problems that all of us see every day as podiatric physicians that lead to ulceration and infection and amputation start frequently as some small problem, not trauma, not an acute arterial infarction, but in general, most of the things we see as podiatric physicians start out, for example, as calluses that break down into ulcers, hammer toes that ulcerate, bunions that ulcerate, Taylor's bunions that ulcerate, or in this case, we're going to talk about web space infections. So here are some patients from my own practice that developed rather significant breakdown, infection, and complications that began as toe web space infections. If we look at the diabetic patient, for example, and we look at predisposing factors for cellulitis, tinea pedis and xerosis are included as common causes. And I might point out, and I'm going to point out to you later, that many of the patients we diagnose as having xerotic skin actually have tinea pedis that's misdiagnosed as dry skin or xerotic skin or whatever term you're using. These are the most recent guidelines from the Infectious Disease Society of America, for example, talking about these patients we all see. They tend to be overweight. They tend to have edematous legs, and they get these episodes of recurring cellulitis. And frequently, this is due to untreated toe web space contamination and infection. So that we want to treat those toe web space infections in addition to making efforts to reduce the edema, whether you do it with just elevation or prescribing or dispensing compression stockings, or whether you prescribe intermittent sequential lymphedema pumps, whatever your technique is. But the point is, this is a recommendation directly from the Infectious Disease Society of America. This is a look at one such survey for the etiology of ulceration in diabetic patients. This is from the Seattle Veterans Administration Hospital, looking at risk factors for ulceration, and tinea pedis and onychomycosis are included in that study. And although I didn't slide it, we always have the classic work of Jeffrey Robbins that showed how onychomycosis is associated with increased risk of infection and ulceration and amputation. So looking at the web spaces in a normal individual, they typically are colonized with dermatophytic fungi. However, when the web spaces become macerated, we begin to get overgrowth of certain organisms, and you'll notice that these are both bacterial as well as fungal, and they are both gram-positives as well as gram-negatives. So once we have a macerated web space, you cannot just automatically assume that it is just a fungus or just a gram-positive or just a gram-negative. And the bacteria that do grow in the web spaces, or I should say overgrow the web spaces and cause pathology, are very frequently somewhat resistant to normal bacterial therapy. So that topicals or orals that typically might work may not work in the case of the web space infection. So these could be rather resistant things to treat, as many of you know from your private practice. This is your basic differential diagnosis of toe web space infections. Erythrasma, as you know, caused by Corynebacterium minutissimum. We may have just a primary fungal infection, which can be a dermatophyte or not infrequently candida. And don't forget, candida infections in immunocompromised patients, not only diabetics, but all these patients we're seeing now that are on immunosuppressive therapies or biologic therapies for inflammatory bowel disease, for inflammatory arthritis, post-transplant, as well as our diabetic patients and our vascularly compromised patients. So these are immunosuppressed patients, and you might consider in the patient that's resistant to what you think is seemingly appropriate therapy that candida may be the cause. You could have a pure gram-negative infection. You could have a pure gram-positive infection. Pseudomonas is quite common in these web spaces. You could have what's called dermatophytosis complex, which again I think is quite common, where you have an initial fungal infection, you then get fissuring and scaling and cracking of the skin, and then you get a secondary bacterial infection, and then you have the less common diagnoses, interdigital psoriasis or so-called white psoriasis, eczema, and so forth. Now, in treating these web space infections, it's important to remember that we also want to change the environment. I believe it was Leeuwenhoek who said a germ is nothing. It's the environment or terrain on which the germ is growing, which is everything. And we've all heard the old dermatology saying, if it's wet, dry it, and if it's dry, wet it. So in treating web space disease, you want to reduce that maceration. So sometimes efforts at drying are very, very important. You want to reduce interdigital compression and skin injury. So this can include anything from toe separator padding to edema reduction to arthroplasties if the patient simply has crowded toes and you simply cannot achieve reduction of that interdigital compression by any other means. So oftentimes changing the environment will make a difference. Erythrasma is not at all uncommon. I think that we tend not to diagnose this as frequently as it does occur. It does occur in the skin, as you see to the plantar right, which was a case of erythrasma in addition to between the toes. It's caused, as you know, by Corynebacterium minutissimum. It is much more common in African Americans, in obese patients, and in patients with diabetes. Heat and humidity certainly contribute to the scaling and fissuring in the web spaces. You know, we're all taught in school that a woods light is helpful, and if you use a woods light, you get this coral red fluorescence. However, how many of us really have a Woods light in our offices. I know I don't. And the treatment for erythrasma is generally erythromycin, 1 gram daily, azithromycin, or topical fusidic acid. So those are common treatments in addition to drying. So there are a number of oral antibiotics and topical antibiotics listed here. You could use some old-time remedies like Whitfield's ointment or topical or oral clindamycin or erythromycin for erythrasma. But the key, of course, is getting appropriate culturing and making an appropriate diagnosis so that you know it's erythrasma. So in the diabetic patient, in the obese patient, in the African American, think of erythrasma. Intertrigo is the term generally used to refer to these multi-organism infections between the toes, and you see lots of different studies with lots of reported different organisms, and they're quite variable from report to report. Many of them have coag-negative staph, Pseudomonas, dermatophytes, sometimes streptococcus infections, which really can spread quite rapidly from between the toes approximately. Here's another study showing predominantly gram-negative organisms causing intertrigos and secondary gram-positive organisms in addition. And so this again points to the fact that we cannot assume that all these toe web space infections are simply a dermatophytosis simplex, that they're simply just an interdigital tinnipetus, because many of these are, again, a mixed bag of perhaps yeast or perhaps dermatophytes with gram-positives or gram-negatives. So proper identification of the infecting organism is required in order for us to provide appropriate treatment for these patients. And with these intertrigos, as you know, the skin gets macerated, it cracks, it's fissures, it's oftentimes sore and raw, and these patients develop these secondary bacterial infections and sometimes a localized cellulitis. And when I document treatment of these patients, particularly in immunocompromised patients and in diabetic patients, I'm very careful to include in my note the fact that these findings are restricted to the web space, and there's no proximal ascending cellulitis or lymphangitis, no proximal bullous formation, no systemic signs of illness. And again, in terms of treatment, changing the environment is very, very important in terms of drying. One can use topical antifungal powders. You can use antibiotics. Those of you that are older may start to dry these by having the patient use Castellani's paint or gentian violet, which you can get, which is colorless. Generally, the pharmacies will have to order that. And in bad resistant cases, using topical steroids. Again, in the diabetic patient and in the immunocompromised patient, candida infections, tropicalis, albicans, parapsilosis, there's a number of species that can occur. Moisture is the key, and you could see by the case on your bottom left as to, in fact, I just had a wonderfully demonstrative case last week in the office, why they call it erosio interdigitalis blastomycetica, because it does cause erosive skin changes. So in treating candida infections between the toes, drying is important. You can use nystatin, you could use fluconazole, topical antifungals that have yeast activity, or topical amphotericin B. But again, the key here is identifying the infecting organism, not just looking at that and saying, well, I know that's erythrasma, or I know that that's just a typical fungal infection. You can have pure gram-negative web space infections, and Pseudomonas seems to be statistically the most common organism, and that makes sense because, again, as you all know, we tend to see Pseudomonas grow in infections that are characterized by the presence of moisture. So antifungal or anti-Pseudomonal therapy is not at all, is appropriate rather. But again, you want to look at the predisposing factors. If the patient is constantly exposed to water or perhaps from sporting activities, whatever, if they tend to perspire a great deal, if they tend to macerate a great deal, then you need to talk to the patient about the reality of their particular foot hygiene and how they tend to overgrow Pseudomonas and maybe restrict um, exposure to hydration. And some of these Pseudomonas infections could get completely out of hand on many of these patients. Less commonly, if all else it comes back negative, you're simply not growing anything, you can consider interdigital psoriasis or so-called white psoriasis, and that does occur. It may occur absent other signs or symptoms of psoriasis, or you might look and do a more generalized skin examination for evidence of psoriasis. Interdigital tinnitus seems to be the thing that most of us think most patients have, but here again, without proper culturing techniques, or identification techniques, I should say, we really don't know what it is that we're dealing with. But interdigital tinnitus, as you know, is associated with scaling and erythema and fissuring. Once again, in the diabetic patient, the immunocompromised patient, this could be more common, and you can have dermatophytosis complex where one gets a secondary bacterial infection. Yeast are also common in many of these patients, and once the secondary bacterial infection occurs, they range from gram positives to gram negatives. So that in these circumstances, we need both antifungal as well as antibacterial therapy. These changes are more prominent in the diabetic patient because we have the effects of hyperglycemia on the immune system and on the skin. So we have a relative immune suppression in the diabetic patient, particularly those, as you know, who are poorly controlled. We then have pseudomotor changes because many of these patients have diabetic autonomic neuropathy and they've lost innervation to the sweat glands and their skin becomes extremely dry. They may have some degree of small vessel or large vessel disease, bad or sad as they say now, and secondary fungal infection. As far as these fungal infections go in the diabetic patient, this is most often mistaken for dry skin. So, and this can be both between the toes as well as the foot generally. So those patients, again, that you've diagnosed with xerotic skin, they're not responding to seemingly appropriate therapy, you might consider either antifungal therapy, getting appropriate diagnostic studies done, or at least using topicals that have some antifungal activity, for example, using a urea and a lactic acid. Now, the presence of fungal infections between the toes and on the skin of diabetic patients is quite common. And most studies average out at about 70% of diabetic patients having tinnitus. And this is a risk factor for skin breakdown. It's a risk factor for secondary bacterial infection. It is a risk factor for ulceration. And again, because of the immunopathy and because of the peripheral arterial disease and because of the neuropathy and because of the skin changes from vasomotor and pseudomotor deficits because of their autonomic neuropathy, these simple problems can become rather serious quickly. And this is where educating the patient is critical. This is where identification of the involved organisms is important and initiating appropriate treatment. Now, and when you do these things, this is a separate problem from their at-risk foot care. And it's a perfect example of where you should be making an evaluation and documenting this. You should initiate a differential diagnosis and document that. You initiate treatment and you document that. And you charge for that with a 25 modifier. So you add an office visit for the evaluation of this problem, the differential diagnosis, and treatment of that problem. When the patient returns to your office for their at-risk foot care, you're going to evaluate their response to treatment. You're going to evaluate whether or not there's been any allergic reaction to what you've been doing, the effectiveness of your treatment, and whether the compliance is, of course, going to be important. Is the patient doing what you've asked them to do? And then you're going to make a decision as to whether to continue or modify that treatment. And here again, you should be charging for that time and your expertise and your thought evaluating these problems with a 25 modifier. Just make sure your documentation is in line. Looking at risk factors for diabetic foot infection, tinnitus and interdigital tinnitus and onychomycosis have been shown to be associated with an increased risk of ulceration and infection. and looking at patients that have ulceration, who are diabetic, abnormal toenail changes, and fungal infections. Here again, in a different study, have been shown to be associated with this. Looking at the literature in general, there does appear to be a link between tinea pedis and onychomycosis and cellulitis in the diabetic patient. And this particular paper rightfully called for improved surveillance and treatment of tinea pedis and onychomycosis. But you're not going to do that unless you take the time to evaluate that patient and identify risk factors and initiate appropriate treatment. Because over time, these simple problems, such as simple tinea pedis, can progress to fissuring, local infections, and more serious infections, and in the presence of vascular disease, infarction, and even gangrene. So, although we start with a relatively simple problem, once again, for lack of a nail, the shoe was lost, and for lack of the shoe, the horse was lost, and for lack of the horse, the rider was lost. So we have these cases, as I showed earlier, where simple toe web space infections have resulted in serious pathology. When we treat the diabetic patients with onychomycosis, and hopefully you are treating them, cutting toenails is not really treating the problem. You want to initiate at a minimum appropriate topical therapy and identifying the infecting organism, and I think making increased use of oral therapy. Keep in mind that when they have onychomycosis, interspace infections with tinea and generalized tinea pedis becomes more important. So we have this so-called pedal fungal reserve. This was a paper, it's almost 20 years old, but I like that term, saying that, look, I tell the patients the onychomycosis and tinea pedis are feeding off each other. Either the nails are infecting the skin or the skin's infecting the nails, and we need to treat them both at the same time. Looking at distribution of these problems, again, some patients just have onychomycosis, some patients have just web space infections, some patients have a generalized plantar tinea pedis, and then many patients have a combination of one or more types that can be found in the individual patient. So diabetic patients very, very frequently are troubled by this problem. Here's one particular paper showing an incidence of 46+% of patients with diabetes having toe web space infections. And again, the organisms range from common dermatophytes to saprophytic fungi to candida. So identification of the organism that's infecting here again is important. Diabetic patients seem to be more susceptible at a younger age to these problems, and in the non-diabetics it increases with aging. So how do we approach treatment then in these patients? Well, it begins by doing a proper history and a proper examination and taking your time and doing more than just looking at that diabetic patient and saying, well, get your toenails done and don't forget to get that note signed by your physician so you get your new diabetic shoes, and then appropriate laboratory studies to see what's involved, in this case, in the web space. So we have several options for evaluation for the toe web infecting organisms. So if we look at cultures versus histopathology versus KOH versus PCR testing, you can see the sensitivity for PCR is superior, the specificity for PCR is superior, and turnaround time, which is important in the patient that has a cellulitis, and we need to know the causative organism. The turnaround time is very important, and again, superior for PCR testing. So in an ideal world, this is where you want to go, by scraping that web space, getting appropriate sampling, and sending that off for appropriate PCR studies. As far as the treatment goes, again, identification of the organism. Is it candida? Is it a dermatophyte? Is it a gram-negative? Is it a gram-positive? Is it a saprophytic fungi? Is it Corynebacteria magnetissimum? Is it a combination infection, a classic intertrigo? And again, the only way to know that is with appropriate sampling and identification of the organisms. We then want to do what we need to do as you think is appropriate in any particular patient in terms of drying. Castellani's pain and gentian violet are certainly options that we apply this in the office while the patient is there. Again, drying techniques, whatever you think is appropriate for that patient, toe separator padding, reduction of edema is very important. Appropriate antibiotic therapy, whether it's erythromycin or tetracycline or Cipro for Pseudomonas. And again, we can do these topically also. Appropriate antifungal therapy, whether it's nystatin or something aimed at dermatophyte infection, and the form you're going to use it in. You're probably not going to use an ointment, but maybe a cream or a powder, or compounding topicals as you need to do so, and appropriate oral therapy. And again, diflucan, terbinafine would be the most common for the fungal organisms. So you want to initiate appropriate therapy, and I think this is not probably done enough. You want to find out if there are family members that could be cross-contaminating that patient, and then everyone's going to have their own feelings on these things, whether you want to initiate appropriate environmental changes or not, because patients frequently will say, am I reinfecting myself with my shoes? And I saw these copper impregnated socks online. Well, that helped. But changing the environment can make a big difference in treating these patients. The tinea pedis, of course, you're all familiar with treating that. And here again, I tell patients like this that a topical alone is probably not going to be sufficient, that we need to utilize oral antifungal therapy for treating these nails, if they're infecting those web spaces. If it's Pseudomonas, 1% acetic acid soaks in addition to oral anti-pseudomonal therapy or topical anti-pseudomonal therapy. With the intertrigos, you're frequently having to utilize multiple therapeutic approaches because, as was mentioned, you have multiple infecting organisms. Just like the non-diabetic and the diabetic, Trichophyton rubrum seems to be the most common organism. In the diabetic patient, the MICs for T. rubrum, for terbinafine and itraconazole and fluconazole is the same. There's no difference between the diabetic patient and the non-diabetic patient. I tell the patients that at a high number, hepatocellular toxicity can occur in 1 in 50,000 patients, at a low 1 in 100,000. I explain to them that terbinafine is actually one of the safest drugs that we prescribe. And I always marvel at people who tell me that they're concerned about potential systemic toxicity in prescribing oral terbinafine, and yet they won't blink an eye in prescribing, say, an oral anti-inflammatory to a diabetic, where the risks of renal pathology or GI pathology, or the patient's on an anticoagulant, and they're not at all concerned about initiating a bleed. They won't think twice about prescribing an anti-inflammatory, and yet when terbinafine comes up, they suddenly get all nervous and scared and weirded out. I can tell you that I have treated many patients with active liver disease, and the leading hepatologist in the St. Louis area, I've had discussions with him about this, and he asked me, why are you podiatrists so terrified of terbinafine? Because he's never told me not to prescribe it to any of his patients. And I mean, to be safe, of course, I get a permission slip from him because these are patients under active management, and he's never said not to give it. And you always have the option of getting baseline LFTs, or I get CMPs actually, and then repeat it at 1 month and repeat it at 3 months, and just document that you've discussed potential side effects with the patient, and advise them to read carefully the printed material that will accompany their prescription, and call with any questions or concerns. So, and every now and then you get the patient that will call and say, I read this, I read that. And if you have an uncomfortable feeling, then obviously don't prescribe the medication or don't have the patient fill the prescription. But the patient also needs to know that when you have advanced disease with matrix involvement in multiple nails and they have secondary web space infections, that this may become problematic in terms of inability to solve the problem. For those of you that are into proper coding, I'll leave this slide up for a moment for the appropriate ICD-10 codes. Erythrasma is one you may not be familiar with. That's L08.1. Pseudomonas interdigital space infections, my recommended code is B96.5. For intertrigo, L30.4. For interdigital psoriasis, L40.9. For interdigital aspergillosis, that's for the skin, not the lung, obviously, is B44.9. For candida infection, it's B37.2. So here again, if I'm concurrently treating these web space infections or concurrently treating the tinea pedis or concurrently treating their neuropathy or concurrently treating their vascular disease or their plantar fasciitis or whatever, their edema, venous insufficiency, whatever, make sure that your note has a proper evaluation, has a differential diagnosis, has a diagnosis finally made, and then the intervention listed. And that will justify your office visit. That's E&M-25 with your 25 modifier. So that's all you really have to do. And from a personal standpoint, if they're there for at-risk foot care and I'm concurrently treating them for another problem, I make the other problem the main focus of that note, and the nail portion is secondary. So it's there, it has to be there, as you know, but I don't say the patient's here for the nails plus. I reverse it and I'll say the patient's here because I'm treating them actively for symptomatic diabetic neuropathy, or I'm treating them because of a web space infection, and they're also scheduled for their preventive diabetic foot care. And again, while it's best to bill for number of diagnoses and complexity of diagnoses and decision making, we all understand that you can also bill for time in consulting that patient. And if you're going to do that, make sure, or at least what I do, is if I add a time component to this, I'm very specific. It's one of the things I don't like about computer generated notes. People tend to get lazy. They depend on these pre-populated notes. And I want my notes to be specific for each patient I see. So if I'm billing for consultation time, for example, I will state in that note exactly what I consulted them about. Whether, so if it's for a web space infection, the need to do this, the need to apply that, so that it's very clear as to why it is I feel is justified. So in summary, this is frequently an infection. It can spread in high-risk patients, such as vascular patients, diabetic patients, immunocompromised patient. It can be associated with significant sequelae. And it goes from being a minor annoyance to a major problem and potential even for limb loss. So it's associated with amputation risk, and patients need to understand that. This will, number one, help you from a liability standpoint, but more importantly, it helps you because the patient now understands, if you explain it correctly, why they need to follow through with this therapy and monitor the response to that therapy. You need to obtain appropriate laboratory studies, because without that, you really have no handle on what it is that you're actually treating. And then initiate appropriate therapy, whether it's for tinea pedis, whether it's for concurrent onychomycosis, whether it's for gram-positive infection, gram-negative infection, and intertrigo with a mixed picture, and discuss all of this in your notes.
So, Dr. Schaefer, when we see our diabetic neuropathic patients for routine foot care. She was under the impression that we could not bill for an office visit with a 25 modifier for something related to the diagnosis to qualify them for routine foot care. Is that the case, or can we bill for the EM with the 25 mod?
Well, I disagree with the people who I know who gives that advice, and I think they're absolutely wrong. I treat many patients for diabetic neuropathy. I treat them with anything from vitamin B complex or alpha lipoic acid to gabapentin to Lyrica to Cymbalta, tricyclics, SNRIs. And I'm evaluating their response to treatment. I'm changing their dosages. I am evaluating them for the side effects. I'm looking for concurrent entrapment neuropathies that might be superimposed on their peripheral neuropathy, and I absolutely bill for that visit.
Okay. Dr. Daniel, hi Ellie, how are you? I've tried to use that, and the NGS would not pay you no matter what. Now what? So I'm seeing my patients for visits strictly at any time. Okay, I think he tried to do that. Is he okay?
Well, I've not had that problem with our carrier. And if it's a problem, then you have the option of just telling the patient that unfortunately with your carrier, they're going to have to come back for a separate visit then. But I just don't have that problem.
Okay, Dr. Perry, can you scrape the web space and bill a biopsy code?
No, I don't think so.
Okay. What are your thoughts on PCR testing for culture? We usually get results within 24 hours.
For what problem? For nails or for web space?
I'm not sure. It doesn't say. It must be, I would think it would be per your presentation on web space.
Well, PCR is your gold standard. It's got the best sensitivity, the best specificity, and the best turnaround time. So that's your gold standard.
Okay. Dr. Goodman, what would be your stepwise approach for treating this severely macerated fourth interspace?
Again, I think the key is identification of the organism. So culture or PCR, whatever you think is appropriate, is number one. Again, separation. I will put some kind of drying agent in there. I'll always initiate drying because, as I say, you had that philosophy expressed 200 years ago that the germ is nothing, the environment or terrain is everything. So drying frequently is helpful. And then, depending on what I'm looking at, I may initiate some initial antibacterial therapy together with a topical. But ultimately, that decision is going to be based, the antimicrobial therapy is going to be based on identification. Everything else is going to be drying.
Okay. Dr. Fry, bills for 11102 for skin scraping biopsy.
Well, I'm not. You just had a speaker that's the authority on coding. I'm the last guy you speak to on coding, so I'm not even sure I know what a 11102 is.
Gotcha. Okay, what is your protocol, Dr. Lee? What is your protocol when a patient comes in initially with a macerated infection and you are not sure of the culture results as of yet?
I'll use some antibiotic therapy. Things like betadine, for example, are helpful because betadine is broad spectrum. It's antifungal, it's anti-yeast, it's anti-MRSA, it's antibacterial. So you certainly could go with an agent like betadine, or you could, if you think Pseudomonas is involved, this 1% acetic acid soaks, and then an appropriate oral antibiotic. If you're not sure what's going on, if you're worried about MRSA, then I'll use typically doxycycline, 100 milligram twice a day, and then I'll either use cephalexin, 2 grams a day, 500 QID, or ceftonir, 300 milligrams BID, or you could use doxy together with Cipro, 500 BID.
How aggressive do you get with oral antifungals with at-risk diabetics initially with cellulitis as well?
I use a lot of oral antifungals. I write many prescriptions for oral terbinafine ever since it became generic. In the old days, when you saw Digger the Dermatophyte on TV, that medication was fairly expensive and insurances wouldn't cover it. At least in the St. Louis area, you're looking at $15 to $20 for the entire course. So I sit down with the patient, I explain to them the realities of why I think they should be on oral plus topical therapy, and that's what I do. So I am very aggressive with oral antifungal therapy. I think, if you look at what are really the alternatives? The FDA clearly states in their policies that you should not represent that lasers cure onychomycosis. We have no evidence that's the case. The only studies we have that imply lasers are helpful have been published by individuals who were consultants for companies that made the lasers, and these were short-term studies, and you have to be careful because if you have an at-risk patient, a diabetic, a patient who's immunocompromised, a vascular patient, if you use an ineffective therapy to make money, you're denying the patient treatment, essentially, because you're giving them something that does not work in a high-risk patient, and therefore they could progress to develop serious pathology while you're collecting your $1,000 cash for the laser treatment or selling them a topical antifungal that has no literature to support its use. So, your decision to do that is it does create harm. It's more than just unethical. It's denying patients who need care the most, treatment. It's one thing to have a 17-year-old girl who's upset because a little corner of the nail's discolored and it's a cosmetic issue. I'm not saying you shouldn't take it seriously, but that's different from a 79-year-old diabetic with peripheral arterial disease and a significant web space or toenail infection that requires treatment. And then when you give that patient ineffective treatment, the 17-year-old, she may have some progression, but it's not likely to harm her. That older immunocompromised patient, you can do some damage. So I make it clear that this is why we need to aggressively treat these things and properly treat these things.
Good. I covered it. Dr. Jerlin, what is the cost for patient for PCR testing? The patients get upset when they receive bills for uncovered services, even if they explain prior.
It is expensive, and occasionally you will get complaints, yes. Okay. I don't know what the cost is.
Dr. Asante, how and when do you use the difflucan therapy?
How or when? When is obviously for yeast infection. Personally, I don't use diflucan for dermatophytes. However, it is a third choice for treating, for example, onychomycosis. If you look at the guidelines of the British Dermatology Association or the American Academy of Dermatology, terbinafine and itraconazole are your primary choice. So, just as an aside, you can use diflucan for treating dermatophytes, but it is not a first choice. And in answer to your question, I'll use one for web space infections. I'll use 100 milligrams twice weekly or 3 times weekly.
Dr. Tabak, you said, do you have any problems with Medicare Advantage plans rejecting claims because you use a 25 modifier?
No, I have not.
Okay.
I think it comes down to documentation. These coding experts put the scare in you, but I always say, if your documentation supports what you did and what you did was legitimate care, let them audit you all they wish. I mean, who cares? You're being a doctor, and you can't not treat patients for fear of these things. But where people get in trouble, in my opinion, and I'm not an expert at this like Jeff Lehrman is. I don't do this for a living, but I've seen enough of it to know from reviewing cases, for example, for malpractice, or I'm also a board reviewer, so I get to look at people's surgical charts when they apply for the boards is that it's just a failure to properly document. People are lazy. They want to just hit these pre-populated notes that say the same thing visit after visit. And I could see where they get in trouble, not because of what they did, but because they didn't document to support what they did. And that's almost always the case. And I always wonder, I guess these people in the rest of the world are a lot busier than me in my practice because they don't have the time to document. And that's where you leave your, I mean, I'm like everybody else. I hate having to stay after hours doing charts. I hate it. I despise it. I'm not documenting for me. I'm documenting for third parties. But it's the reality of the world we live in. And I think if you do that and you do it properly, then you shouldn't fear any kind of an audit because you're practicing medicine the way it's supposed to be practiced.
All right, this is the last one. Whatever we didn't get to, we will get to after. Bill, Dr. Taryn, okay to prescribe, is it terbinafine?
Yeah.
In patients with in patients who have cleared Hep C with antiviral?
I believe so. Like I say, the patients I have who are under hepatology care, they've never been turned down for terbinafine. I mean, it's just not happened.
Okay. Dr. Jacobs, always a pleasure working with you. Pleasure seeing you. Thank you so much for your contribution to podiatry in this particular event. I will be in touch soon.
And Rich, thanks for your help with the computers. And I didn't think we were going to make it there for a minute. I still haven't found that share screen button, but have a good rest of the meeting.
Okay, buddy. Be well.